method of infection or for infection with a non-virulent bacterium. As you can see, there is no period of time for assessing infection control between explantation and reimplantation. We are done in the same time. Duration of antibiotherapy is short, about 4 to 6 weeks, seldom 12 weeks. Second, the two steps procedures. We have to consider two options, early and delayed exchange arthroplasty. Early delayed exchange, that is 4 to 6 weeks, arthroplasty is commonly used for non-multi-recurrent infection or joint infection without large bone defect. There is no antibiotic-free interval between and a short period of time for assessing infection control, only clinical, biological, conventional, but not bacteriological sampling. In case of two long steps, we have first explantation of the infected knee prosthesis, then antibiotic therapy during 6 weeks to 12 weeks, then a 2-week period without antibiotic, which allows joint aspiration for bacterial culture during after this period. And reimplantation is permitted if bacteriological and histologic examination are negative. This strategy is theoretically optimal for assessment of infection control, but possibly detrimental for the functional result if the delay of reimplantation is too long. What are the specificities of anti-infectious treatment? Strong doses for local antibiotherapy. Strong doses of antibiotics may need to be used for local therapy. So this type of cement are different from marketed cement used as prophylaxis. They are prepared by the surgeon extemporaneously in the operating room and are only recommended temporarily in two presentations: cement best used to fill a cavity, spacer with cement for a joint. We have to remove secondarily these beds or spacer. These cements must in no case dispense from a prescription of general antibiotherapy. The prescription of systemic antibiotherapy for bone and joint infection is subject to some rules. First, document the infection, but antibiotherapy must be initiated before in a probabilistic manner, after collecting microbiological sample and before obtaining these results. Antibiotherapy initiated most often as a combination, achieving high plasmatic concentration, using molecules with a good bone distribution, and in case of infection due to staphylococci, never use monotherapy with rifampicin, fusidic acid, fluoroquinolones, and phosphomycin. It is recommended to administer the treatment initially intravenously. No study has validated the duration of parenteral antibiotherapy. It is usually 15 days long. After this, it is recommended to switch to parenteral administration under the condition that antibiotics have good bioavailability and a good bone distribution. Antibiotics have no negative interaction with other drugs, digestive tolerance, and a good observance. If switching to oral treatment is impossible, that is, for example, for glycopeptides, it is mandatory to find a way to maintain parenteral antibiotherapy as long as necessary, either in the hospital or in ambulatory care. In this case, it is recommended to insert a central catheter, which may be changed if the planned duration of antibiotherapy is inferior to 6 weeks, or a totally implanted central venous access device if the planned duration of antibiotherapy is over 6 weeks. It is recommended to administer antibiotic treatment for a minimum of 6 weeks. The usual length of treatment reported in literature is 6 to 12 weeks. Maintaining antibiotic therapy beyond 12 weeks should be discussed. It is recommended to control the effectiveness and tolerance of antibiotic therapy. Effectiveness is assessed first on clinical data, but also on biological parameters, CRP. It is recommended to dose some antibiotics, such as glycopeptide or rifampicin, or if rifampicin is used, to dose the antibiotic which is combined, because there is an enzymatic induction by rifampicin. Tolerance is assessed by interrogation of patient with biological parameters. It is also necessary to measure blood concentration of some antibiotics which are toxic, such as amenazide trough level. We have not enough time to detail how to choose antibiotic according to the microorganism, so we show you on this slide an example for methicillin-resistant staphylococci. This slide is to emphasize that pharmacodynamic and pharmacokinetic characteristics of antibiotic necessitate rules for appropriate dosage and mode of administration. For example, we use continuous infusion for vancomycin and some beta-lactams. Empirical antibiotic therapy, it's the antibiotic scheme to recommend before obtaining peroperative bacteriological studies, or when there is no reliable documentation in the patient's history and when there are general signs indicating the emergency of treatment. Several combinations of antibiotics can be used. They must be adapted according to the microbial ecology of each institution. The following broad-spectrum combinations are suggested by order of preference. Suppressive antibiotic therapy. This palliative strategy consists in maintaining antibiotic therapy pairs for an undetermined length so as to inhibit bacterial growth around the prosthesis. It applies to situations for which the bacterium is documented and the infection persists in an inoperable patient with a non-loosened prosthesis. It can be used only with well-tolerated molecule and easy administration, that is, PEROS. Optimal management requires an accurate clinical evaluation, a microbiological diagnosis requiring validated techniques, both for sampling and for the identification of microorganisms, a therapeutic strategy defined during multidisciplinary staff meetings, implementing specific treatment, especially for surgical and anti-infectious goals in the short term, a global continuous and clear management until coming back home with a computerized file including the detail of care and continuous information of the patient during all the healthcare process. In France, 8 inter-regional reference centers for complex osteoarticular infection were labelized by Ministry of Health in 2008. Is cure possible? The infectious and functional criteria should be taken into account. First, there is no criterion defining infection cure. It is recommended to follow up patients between 1 to 2 years after the end of antibiotic therapy.